Hello, everybody. My name is Christopher Kopreski, and today I will be discussing the variations in clinicians' perspectives on the impairments, needs, and goals of mild stroke survivors. Now, nearly half of all strokes are mild strokes. Evidence suggests that mild stroke survivors may have cognitive, physical, and psychological impairments, and that 30 to 60% of all mild stroke patients suffer from executive dysfunction. However, because mild strokes have historically not been seen as a significant disease, there is no well-established system to identify, let alone treat mild stroke. In fact, previous literature has identified significant variability in the nomenclature and criteria used to classify mild stroke with current stroke assessment tools, which could lead to worse patient outcomes. So for this study, we wanted to explore to what extent do clinicians' perspectives on mild stroke vary. Differences in clinicians' perspectives about what stroke looks like, what these mild stroke survivors want and need, might explain the significant variation in mild stroke classification and treatment. So this is a qualitative exploratory study. 9 clinicians of different professional backgrounds were interviewed in a semi-structured format and asked about their perceptions of stroke. Interview transcripts were inductively coded for mild stroke, and thematic content analysis was used to create a codebook and organize this information into themes using the NVivo 12 software. So our first of 3 parent themes was impairments from mild stroke, and only 3 of 9 clinicians mentioned psychological deficits, whereas physical and cognitive deficits were mentioned more frequently. Specific kinds of impairments mentioned within these broader categories also heavily varied, as shown in the following word clouds. Noticeable impairments like speech and walking deficits were mentioned more frequently, whereas subtle impairments like memory, fatigue, personality, and mood changes were all less frequently mentioned. This perhaps explains why invisible deficits and cognitive deficits are often undocumented and never treated. Going even deeper, we find inconsistencies in the perspectives themselves. A social worker says cognitively it could be a wipeout in regards to mild stroke. And in contradiction, a physician states, if cognition is majorly affected, then I won't call it a mild stroke. We see similar inconsistencies in our next parent theme, resources needed for mild stroke. And for instance, some clinicians state that adaptive equipment, caregiver support, and post-acute care services are important needed resources, and other clinicians state, well, the exact opposite. Here's an example. A social worker says during a stroke, there are long-going needs for rehab. If it is mild, what is their discharge follow-up? In contrast, a physician states, by definition, mild stroke patients go home. Now, our last parent theme was goals and wants of mild stroke survivors. Clinicians identified that mild stroke survivors want to return to work or volunteering, walk normally, live independently at home, and 3 of 9 clinicians mentioned that stroke survivors want access to post-acute care information and services. Thus, clinicians not only emphasize that stroke survivors need post-acute care, but also want it as well. This suggests that referral to services and continuation of care is a particularly important component of mild stroke treatment and should be recognized by clinicians. Now, this study suggests that there are significant differences in clinicians' perspectives regarding the impairments, needs, and wants of mild stroke survivors, and this could possibly create communication barriers among the stroke care team, result in misclassification of mild stroke, and impede stroke treatment and patient referral to post-acute care facilities. We believe future research should focus on developing a consensus definition and standard of care for mild stroke to improve both mild stroke identification and intervention. Thank you so much for listening.